time. So,
All right.
Okay, we're live. Welcome everybody to Professional Novice. My name is Ali Rizvi, and today I'm with Brian Earp, recently Dr. Brian Earp, right? Congratulations, Brian.
Thank you.
Yeah, this is great. I mean, Brian is one of my favorite people. I love following the things that you write, the stuff that you publish, your Twitter feed, everything you share is just absolutely fascinating. You seem like a very curious person. You're also a very, very kind person. So I got to say that, it's really nice to have you and to speak to you again. And Brian he's the associate director of the Yale-Hastings Program in ethics and health policy at Yale University. And he's also a research fellow at Oxford University in their Center for Practical Ethics. And Brian is the co-author of this the provocative book, Love Drugs, The Chemical Future of Relationships. Right. So, and the questions they ask is, would you take a drug to help you fall in love? Would you take a drug that would help you break up with somebody that you were in love with and sever those emotional connections? Can these drugs be used to modify our sort of romantic lives and our relationship lives? And at this point, recent advancements in science and medicine and just technology are making these kinds of drugs a reality, and some of them already exist. So many of us know about MDMA, ecstasy and Molly, and psilocybin or magic mushrooms, and how these are being used today to help enhance relationships and foster human connection. And for example, couples counseling, they're also being used to treat several other psychiatric diseases like PTSD. So, we're going to talk about questions of this, some of the philosophical, look at it from a philosophical angle, from an ethical angle, and look at the ethical implications of chemically modifying our relationships in this way. So, Brian, I have so many questions to ask you, and I hope we can get through it in this hour. But first, it seems like this project started at from what I can gather, the Oxford University Center for Practical Ethics, right, where you are a research fellow, and your co-author is Julian Savulescu, I guess I'm pronouncing it correctly, is chair. So you wrote the book with him. So how did the book come about? Was this a focus of your research there, or are there other reasons, maybe a conversation or professional, academic, or even personal reasons that got you interested in this?
Sure. It's kind of a funny story. So 10 years ago or something like that, I was doing a master's degree at Oxford in experimental psychology. And I had presented some work at a conference that got picked up by the British media. There was a study I'd done as an undergrad where we showed that incidental exposure to no smoking signs, ironically, triggers cravings for cigarettes in smokers because
I know that, yeah.
although right, you hadn't been thinking about it, but now it's on your mind. So it was kind of ironic. And anyway, the media took an interest. And then I saw a blog post by Professor Savulescu talking about the practical ethical implications of knowing how our minds actually work, as opposed to how we think they'll work. So if you plaster a city with no smoking signs, thinking that that's going to, maybe it's serving a legal purpose, letting people know where it's not permitted to smoke. But anyway, it may have this ironic side effect of increasing smoking in some contexts. And so he wrote this interesting piece just reflecting on how doing ethics in the world requires understanding psychology. And I thought that was a good point. So we ended up just talking with each other, and one thing led to another. And he invited me to stay on and do a DPhil with him because I also had a background in philosophy, and he's in the philosophy faculty. But at the time, I was still motivated to pursue this theater career that I had been involved with in parallel to my academic life for many years up to that point. And so I didn't feel ready to commit to doing a PhD, a doctorate. So I said, that's just a wonderful opportunity you've created here, but I think I'm going to have to decline and go back to the States and keep doing theater and so forth. And then he came back with the idea, well, what if I hired you to work on a project of some kind that you could do from a long distance? So, research it, send in a chapter now and then. And he proposed expanding on some ideas in this love drugs area into a book-length form. So there's a paper written in 2008 between him and Anders Sandberg, sketching out some of these ideas as sort of initial offering. And then, this opportunity came along to turn this into a book-length project. But I had not been thinking about any of this stuff to that point. I thought about love in the way that many of us do, which is just from my own experiences, from stuff that I've read in literature, from poetry that you grow up with. I mean, I had the same kinds of general thoughts and intuitions as many people have, but thinking about love from a scientific perspective was not at all on my radar. And so I had to learn a lot of new material and then think through the philosophical implications of viewing love through this particular kind of neurochemical lens.
Mm-hmm. So yeah, speaking of that neurochemical lens, so let's start by talking about some of the endogenous chemicals that we have that, you know, we all come pre-stocked with, that play a role in our relationships. Like, well, there's testosterone, obviously, there's estrogen, dopamine, serotonin, epinephrine or adrenaline, and then there's the love hormone, which is oxytocin. So we already know that you know, the role of, say, SSRI antidepressants, you know, how they increase serotonin levels, and then MDMA can actually do the same thing at a much greater magnitude. So to what extent are the love drugs that you're writing about in your book, to what extent are they just modifiers of our endogenous sort of physiological, hormonal, and neurochemical landscape versus actually being sort of synthetic external things, which I assume is probably further in the future?
That's a good question. I mean, there may not be a bright line distinction between those things. At some point, chemicals are chemicals, and they have whatever practical effects they have on your neurochemistry and on your subjective experience. And so trying to identify certainly the natural versus artificial distinction begins to break down, because you can make a chemical substance in a laboratory that has certain effects on your brain, and you can also find chemicals out there in nature that have certain effects on your brain. And in some cases, those effects may be indistinguishable. We can take an example that you raise, which is SSRIs, a common class of drug that inhibits the reuptake of serotonin. And this is commonly used as a treatment for depression. And so it interacts with our serotonin system that we have endogenously. And the question about how this affects love is maybe a two-part answer. So the first is, SSRIs can certainly affect relationships. Everybody knows that, because they can have, in a pretty high proportion of cases, negative implications for libido. So many people find that they effectively lose their sex drive. And so if you're in a romantic relationship, and if sex matters to you in that relationship, and if it's one of the things through which you and your partner enhance your love, then having a chemical which inhibits that process could have knock-on effects for your relationship. So a general point that we make in the book is that we are already using a lot of chemicals that influence our neurochemistry in complicated ways, but because of the individualistic lens of Western medicine, where the way that drugs are tested is in terms of their effects on discrete symptoms of individuals. So if you want to trial an SSRI as an antidepressant pill, what you're going to give the trial participants is a survey asking about their symptoms of depression. But if you don't also ask, for example, how's your relationship going? Have you noticed any changes in this? You know, tell me about these other kinds of things. It doesn't mean that the drug isn't affecting those interpersonal variables. It just means that the scientists didn't bother to measure that. So one thing we try to say is, if we're going to continue to prescribe powerful chemical substances in the form of medicine, we have a responsibility not just to look at how it affects my personal internal feeling of depression or something like that, but how it affects my relationship to others, in part through these chemically kind of mediated states. So that's the part one answer. The part two answer is that some of these drugs can, as it were, directly induce a feeling of at least warmth and affection, a feeling that some people would describe as love, whether, you know, mistakenly or accurately. So MDMA is well known for subjectively causing states of mind that many people find indistinguishable phenomenologically from the way they feel when, without the use of drugs, they find themselves, as it were, falling in love with someone. Now, here you do get questions about authenticity. You know, if I meet somebody at a party and maybe I'm using a more commonly accessible drug like alcohol, and I spend some time with them and just through getting to know them and the stories that we're sharing, and maybe I'm a little bit in a different state of mind because of the drink, but I find myself just falling for this person, maybe over multiple interactions.
Yeah, beer goggles.
Yeah, well, so you have beer goggles going on, and that might potentially fade, and then you're still gonna have to see if you get along with the person. If you only like someone when you're, you know, have had 2 glasses of wine, that's probably a red flag. So, you know, that feels a certain way. If you meet somebody under the influence of MDMA, you might, in a quicker and more potent way, have an experience that subjectively feels similar. But many people would want to immediately draw a distinction between these two ways of arriving at that feeling. One of which is contextualized within an ongoing relationship, where you have knowledge about the person, where your representation of the person in your mind is sort of, you know, embedded in your emotions in a stable way that's integrated in with, you know, other parts of your psychology. Whereas if you introduce a drug into the situation that, as it were, directly leads to the same subjective experience, some people would say it's not contextualized in the right way for that to be, I mean, whether you want to call it authentic or not, it's not reliable, because then when the drug goes away, potentially so too do those feelings of connection. And one thought is,
Right.
in order for a feeling of connection to be authentic, it has to be the sort of thing that persists through various interactions. If it's highly contingent on whether you consumed a substance, that's a good sign that maybe it's the substance doing the work, rather than something that's more deeply integrated within, you know, the fullness of you as a person and the fullness of the relationship that you're building with someone else.
Yeah. So one of the questions, I guess I'm thinking about this, you know, while you're talking about it, is that came to my mind that I was thinking about was just identity, as in who we really are. Because when you start talking about chemical modification, so when we talk about, like, for instance, when we talk about the existence of a soul, you know, well, everything about us as people can be explained, I guess, by four things, right? There's genes, neurons, neurotransmitters, and hormones, and I think that can pretty much determine everything about your soul can be explained by these four things in different
Well, and our
combinations.
social and historical context, and our relationships, and the cognitive content of our beliefs, and so forth. I mean,
Yeah,
you're,
right.
you're, yeah,
But what I'm saying is, like, all of those things are also kind of they're contained when we're talking about cognitive. When I say neurons, I mean your memory and, you know, the way you
right.
process things and all of
Everything
that.
that's underwritten by neuronal
By
activity.
neuron,
Right.
yeah. So so for example, like if you have a genetic defect, you know, you can be a totally different person. If you destroy a good amount of your neurons, you know,
Right.
all
Okay,
of
I
your
see what you're
cognitive
saying. Yeah.
experiences and everything, like in like Kurzweil's Jacobs or mad cow disease, or, you know, Alzheimer's, then you become a completely different person. If you tweak neurotransmitters like serotonin, you can become ecstatically happy, or you can become suicidally depressed, independent of the environment or the circumstances you're in. And, you know, again, if you ramp up your dopamine, you know, you can develop psychotic symptoms. You can develop delusions and paranoia, like they do in schizophrenia. Dampen it down, then you get Parkinsonian symptoms, and that also includes depression and so on. So, so in your book, you also mentioned, for instance, emotional blunting, right?
Yeah.
And emotional blunting is something that happens with, you know, you talk about SSRIs. It can happen with SSRIs, it can happen with mood stabilizers, like the ones that they use, for example, in bipolar disorder. And that can actually make you more numb and less sensitive to others, right? So I guess, you know, you're taking SSRIs to feel better about yourself, but if you're in a relationship, you might become even less sensitive to your partner. So once you bring all of these chemical modifiers into your relationships, do you really know who you are, who the person you're with is, or is your love really real if you're both just sort of chemically modified alternatives of yourselves? So that identity aspect, like that, what do you think about it? I know it's a very long, winding question, but
No, that's a great
yes.
question. Yeah. Yeah. Okay. I thought about this a lot, so I'm going to try to be relatively concise. But I think you've raised some pretty thorny philosophical questions, and we might have to put some theoretical tools on the table just to begin to answer this. So
Take your time. You don't have to be concise. Yeah.
Yeah. So, on the example of SSRIs, you're right that I first emphasized this seemingly low level effect of the drug, which is it can interfere with your libido. And then that could obviously affect your relationship indirectly. And then that can kind of affect your sense of yourself and how you relate to the person. But the direct effect of the drug feels like a bodily effect rather than effect on the person, if you want to distinguish those things. We are obviously embodied people. So, okay. You raised that SSRIs can have an additional effect, which is that they can block these sort of higher level feelings. Your feelings of sadness, which is maybe the point of the drug, but also your ability to, in some sense, care about the feelings of other people, maybe the sadness of your partner. And now this starts to feel like this touches on conceptual views about what love is all about. So let me spell this out. Many philosophical views of love suggest that it requires, among other things, care for the other person, where care is defined as basically unconditional responsiveness to the other person's needs. So when I care about you, I want to help you out just because you need help. And I want you to flourish for your own sake, not because I expect I'm going to get something in return. So as you move away from a kind of transactional relationship with someone toward one where you unconditionally support their flourishing, whether or not you're going to quote unquote get something out of the bargain, that seems to be a core requirement of love, whether it's parental love or familial love or love of a friend or love of a romantic partner.
Mhm.
And so there's this interesting thing where if I'm taking a drug that prevents me from caring about you in a certain sense, and I can finesse that point too, there's a way in which the drug is sort of undermining a core ingredient of love on this philosophical view of what love is. Now, you can imagine that if I stop taking the drug and then I suddenly find that I'm able to be responsive to your needs and I've listened to your sadness and I take care of you in the way that I used to before, you would want to say, isn't that unfortunate that the drug is sort of temporarily interrupting my ability to maybe express or manifest my care? But you wouldn't want to say that I'd fallen out of love with you just because, while I'm on the drug, it's a little harder for me to respond to your emotions. But you could think about this at a deeper level, which is if you're suppose you have to take an SSRI for like the rest of your life because for whatever reason you can't function without it. So the alternative is just a life of disarray or despair or something like that. So suppose you've got to take the drug indefinitely, and it isn't that the effect can be described as just you're not able to manifest your care in any given moment, but that you sort of find yourself not motivated by the suffering of your partner at a deeper level, where you just kind of don't care.
Mm-hmm.
Then I feel like it might be right to say that you don't love them anymore. That regrettably, a side effect of this chemical substance is that it has, in the actual world, undermined your love for your partner. And both of you might feel really sad about it. You might say, gosh, I remember how I used to feel. I used to care when you were sad, but frankly, I don't know. I can't bring myself to care when you're sad. And I may be entirely due to the drug. But even so, that's our reality. We're in a relationship here, and I'm not responding to your needs, nor do I feel motivated to respond to your needs. I would say the drug has quashed a feeling of love. And so then you might be thinking about like, okay, that's maybe a proof of concept that a drug can have an effect on the identity of a phenomenon, where here I'm talking about the identity of a relationship. Is it a relationship that's fundamentally based on love? If the drug can impair that, it seems like it can have pretty radical effects for the identity of a relationship. And you might also think it could do the same for your sense of self, which is what you were talking about. Right. So one way of making that point is that our sense of self is largely shaped and constituted by our relationships with other people. So the phrase of no person is an island, the sort of paraphrase of John Donne, is really true. Our identity is not based around it being an island. Our identity is co-constructed with all the people in our lives with whom we share these intimate relationships. And so if a drug can fundamentally alter the way we relate to other people, the degree to which we care about their needs, the way in which we manifest our feelings toward them, then you can imagine that our sense of self can also radically change.
Yeah.
You brought up Alzheimer's, which is a really interesting case. So there's a lot of debates about what happens in Alzheimer's with respect to the personal identity of the person. So if you think personal identity is based around continuity of memory or something like that, then you might think that loss of certain kinds of memories is enough to break that identity relationship. If you think that a person's identity has to do more with the sense of their character, what their disposition, how they're disposed to treat other people, then Alzheimer's can have different effects because, for some people, it doesn't necessarily interrupt their caring nature. It may be more confined to memory. And then what some people in bioethics are now arguing is that you may, as a community, want to help the person preserve their identity through the relationships that you have with them as they're experiencing these mental deteriorations in terms of certain cognitive features. Mm-hmm. And so I think thinking about identity is something that is upheld in some sense by our role within a social network. And then seeing how chemical substances can affect our relationship to others is one way of getting into the idea that it can radically affect who we are, depending, of course, on your philosophical view about what it means to be a person.
Yeah. That's it. So, you, in addition to, I guess, these chemical modifiers, I mean, even like I remember the studies of hormonal contraceptives, where they would say, there were many women who took, for example, oral contraceptives that were hormonally active. And while they were on these oral contraceptives, they were attracted to very different men. And then when they come off of the hormonal, so they'll feel attracted to somebody, we start a relationship with them, get married to them. And then they decide that they want to have children, and then they get off the hormonal contraceptives, and suddenly they're attracted to a completely different kind of person. They're not attracted to the person they're with anymore. So I guess I imagine there must be analogous situations when it comes to some of these other drugs that we're talking about. Like, you said that with the SSRIs, you get to a point where, okay, I don't really care about you anymore. Can it work in reverse, that once you get off of your SSRI treatment regimen, then you come back, and is it reversible in the sense that, okay, wow, I really did care about you? Is it?
Yeah. I mean,
happen?
it's probably going to be a lot of individual differences, and it depends on what goes on in the relationship in the meantime. Because, if the relationship disintegrates to such a point that you go off the drug and suddenly you feel like yourself again, but the relationship is already damaged beyond repair, then, maybe there's nothing that can be done about that.
Mm-hmm.
I do want to make sure that SSRIs are acknowledged as also being beneficial for some people, including with respect to their relationships. So, there are a lot of problems with SSRIs, and the clinical data on their effectiveness is really an interesting conversation, because it seems like a large proportion of the treatment effect, when it exists, is down to placebo. And there's a lot of debate about how much is actually due to manipulating serotonin levels, in terms of whether that actually is helping the person, recover from depression. Nevertheless, it's clear that there's a subset of people for whom SSRIs are an effective treatment for very serious depression. And so just play that out in the relationship context. If I'm really depressed, and as a consequence of that, I can't get out of bed, and I can't participate in our relationship, and I can't be motivated to help you out when you need help, and then I take a drug, an SSRI, and I happen to be in that lucky subset of people for whom it is an effective treatment of depression, and then I say, gosh, now I feel like myself again. So you can get the inverse thing here, which is that for some people, the feeling of depression is the inauthentic phenomenon. And, maybe they remember themselves as a child, and they said, I always used to be so happy-go-lucky, and, just my sense of myself as a joyful person. And ever since this depression set in, for whatever reason, I mean, the etiology of depression is complicated and different for different people. Ever since I became depressed, I just don't feel like myself. People will say that. And again, some people who take SSRIs will say, because I had access to this drug and whatever other treatment modalities I'm pursuing, I feel like I've rediscovered myself, or I really feel like myself again. So SSRIs, depending on who you are and the dose and what you're dealing with in your context, can for some people be identity disruptive, and for other people they can be identity reconstitutive, if you want to put it that way.
Yeah. So can you sort of walk us through? I mean, we talked about you wrote in the book about MDMA and psilocybin, or magic mushrooms. So can you kind of just walk us through, supposing there's a couple that has become stagnant or distant and non-communicative over time, which is not infrequent after, say, many years of being together, and we've heard examples of people how they're treated with MDMA or with psilocybin or some of these other drugs, and immediately they're connecting again. So how does that work in say, like a real life couples counseling type session? How would that enter the picture?
There's two main sources of evidence for what I'm about to say. One is data that comes from the 1980s, when MDMA was openly and actively used as an adjunct to couples counseling, before it became listed as a Schedule I substance and was prohibited even for therapeutic and research purposes for a long time. So there was a period of time of multiple years where MDMA was primarily being used as a therapeutic agent, as an have a lot of randomized control trials or anything like that. It's mostly clinical experience and case notes and so forth, and then people reflecting on a series of cases. More recently, you do have randomized control trials, or at least randomized trials. It's hard to control because you often you can tell if you're on the drug. So it's certainly not going to be that you have a proper placebo and that you're not sure if you're which arm of the trial you're in. But in some of these recent randomized studies that have been focused on individuals, and primarily individuals with severe issues, for example, having to do with post-traumatic stress disorder, you're getting some indirect evidence of the effects on relationships in the following way. If I have PTSD, that is typically really bad for relationships. If I'm having uncontrollable outbursts of anger or aggression, or I freak out at the slightest indication of something that reminds me of the trauma or whatever it is, PTSD can be something that is really difficult to handle in a relationship situation. And so the simple point is, insofar as MDMA-assisted psychotherapy is an effective treatment of PTSD, and it seems to have treatment effects that are much larger than other treatments that have been tried, then simply by resolving this impairment to my relationship, I may find that I'm better able to connect with my partner. I'm not having these outbursts. I'm not so easily triggered.
Mhm.
So that's an indirect way in which can have effects for relationships. And some participants in these trials will report those kind of effects. There's also been some trials in so-called healthy normals, which is kind of a loaded term, but it basically means there are research volunteers who have been assigned to a treatment or a control arm for MDMA and also for psilocybin from magic mushrooms, who aren't dealing with any particular mental health issue. It's just a question of how does this drug work on people who are, within the range of non-clinically diagnosable mental health. And interestingly, in some of these early studies, people would just voluntarily report that they found themselves going home and interacting with their partner and seeing them with new eyes. They say, listen, I'll tell you about whatever my experience was like in the trial and how it affected me in my daily life in the ensuing weeks. But also, I noticed when I went out with my partner of 20 years that it was almost like we were 16 again. I found myself able to kind of clear away the dross and all the gunk and the filth of the last 20 years of our relationships, these tired habits that we would get into, these stimulus response loops where they say something and I immediately react defensively because, we're just so used to reacting that way. There's different theories about what exactly MDMA is doing. There's different theories about what psilocybin is doing. But one view is that what these drugs can do is sort of wash out some of our priors. I mean, if you think of our brain as like a Bayesian prediction machine, partly what these drugs do is just dampen down some of these prior habits, to put it that way, such that we can develop new habits, such that we can be more flexible and responsive to our situation, take in information, take in the kind of posterior information, and give it different weight to what we would if we hadn't taken the drug. So that's some further evidence that for some people, it puts them into a mentally flexible state, whereby they're also noticing things about their environment, including their partner, including their relationships, where they're simply in a mindset where they're more open to seeing their partner with fresh eyes. And for some people, that can be really helpful for a relationship that's grown tired and is beset with these unhelpful habits.
And is it enduring, like in the sense that when you're on this and when you come off of it? I mean, that's sustained, that kind of feeling once you've experienced it.
So for psilocybin and for MDMA, particularly for psilocybin, I will say, many people report a sense of increased mental flexibility, a sense of approaching the world with a kinder heart, a sense of better functioning within their relationships. It lasts for many months after a single such exposure. So the effects seem to last for quite some time. It isn't just like for the next 2 days and then you revert to baseline.
Yeah, that's that's interesting. I think so. I think many people are familiar with the relationship boosting drugs like MDMA. I mean, I think I was reading something about how for narcissistic people who almost never require, they never really seek therapy because they don't think there's anything wrong with them.
They're perfect.
Yeah, they're perfect. So they don't, they have a reduced capacity to feel empathy. They tend to, with MDMA, they're able to, especially in couples counseling, they're able to actually empathize in a way that they aren't able to normally.
That's incredible. I haven't seen those studies, and that's fascinating. I would love to read up on that. Yeah.
I think and I'll actually look for it. I read it a long time ago, but that was kind of interesting because it does foster empathy, a sense of sort of connection with everybody around you, which I think is interesting, especially for some of those. And I don't really know if there's anything that's been done for psychopathy and some of these other things, but potentially, just theoretically, and I know that the mechanism of action and clinical efficacy cannot be really correlated. I know that's a big no-no at the point, but it's interesting to think about. So we're familiar with the relationship boosting effects of MDMA or psilocybin and other medications like this, but you've also talked about drugs that help you in breakups, that help you sort of sever those emotional ties and deal with the breakup. So there was kind of an interesting part in your book and I'm going to be paraphrasing it, so let me know if I get anything wrong. But you talked about there's 3 different ways. There's prevention of actually getting into something that would be, so there's a preventive aspect where the breakup, where something that's inevitably, I guess, headed for a breakup, you would avoid that situation. Then there's actually being in a situation you want to break up, and it sort of helps with the pain, dealing with the emotional, makes it just more emotionally tolerable. And then you have something like in the movie Eternal Sunshine of the Spotless Mind, where you have you're just getting rid of the memories, or selective memory erasure, or of a painful breakup or relationship. So are there actually, because this is something I wasn't as familiar with, are there drugs, are there chemical modifications that you can do that actually help in this area of
Yeah. Okay. So you're right that the other kinds of things are a little bit more straightforward. I mean, many of us use drugs in the context of breakups, in that we may drink more than we normally would, or we go have a tub of ice cream, or we overeat, or something like that. I mean, there's lots of ways in which we take chemicals into our bodies to try to help with the pain of a breakup, and that can be done, in a relatively responsible way or in a really damaging way. But nevertheless, we're all familiar with the idea of turning to certain kinds of drugs in the context of a breakup. The memory modification thing, it sounds a bit more sci-fi, and so I'll explain about that. There is some work on what's called reconsolidation therapy, which is a drug-assisted therapy that is primarily associated with a psychiatrist in Canada named Elaine Burnett, or Brunet, I'm not sure how to pronounce his name. That was originally developed as a treatment for PTSD. And so I'll just first say how it works, and then kind of maybe talk about it more abstractly. So concretely, what it involves is you go into the clinic or the office or wherever this is happening, and you will, after getting debriefed or about how it's supposed to go, you'll write out a memory that typically causes you to have a kind of hair trigger traumatic response. So, it might be a memory of an assault or something like that, or it might be your memory of your time in the war. So let's just say classic PTSD triggers. What many people would like is they want to preserve the content of the memory, because they want to have continuity in their life narrative. You wouldn't want someone to say, yeah, I simply don't remember that I was assaulted. It seems like that's questionable if you're going in there and deleting memories somehow. We want to know what happened. We want to have a factual sense of our life. But we would like to be able to have the memory without it causing this triggering emotional response every time we reflect on it, so that we can't move on with our lives. So what the goal of the therapy is to call up the memory. But while you do this, you've taken a drug called propranolol, which is a beta blocker, which sort of settles down some of your emotional responses. And so what you can do is you can experience what it's like to have the memory without having that automatic emotional response associated with it. You sort of just literally have that experience. And then you can sort of restore the memory, hopefully with some of the emotional triggering aspect of it stripped away, so that the next time you call up the memory, you still have it, you're still there, you still remember what happened, but it doesn't have such a strong emotional response. So the psychiatrist who came up with this treatment has made a really interesting point, which is that when we think about traumas in our lives, certainly in the context of a clinical diagnosis like PTSD, there's a classic set of types of things that we think may cause one to be traumatized in that way. But he says, there are aspects of ordinary life, like a relationship betrayal, your partner of 20 years, let's say, who suddenly leaves you, abandons you overnight for, some other relationship, or, certain breakups for certain people when they felt that they were, planning their life with someone, and they couldn't imagine themselves taking another path. And then all of a sudden the future looks destroyed. For some people, he said, rightly, this can be among the most traumatic types of experiences of our lives. So you can be within the top 3 or 4 things that we say are the worst things that ever happened to us. It might be a certain breakup.
Yeah, I think it's
yeah.
Yeah, sorry to interrupt. No, I was saying a lot of it has to do with what you said about the future vision, because part of what depression is really not seeing the hopelessness, not seeing a vision for the future. And if you've built your entire vision of the future with somebody, and then suddenly that's taken away, you have to rebuild it. You have to start from scratch. And I think that can be that can be very traumatic, even more so than, I think, say, the death of a parent who doesn't really figure into your future plans or future visions, in a sense. So Yeah, that would make
Yeah.
sense. Yeah.
And one concern that I can imagine people immediately wanting to raise here is that sometimes when we go through a breakup or a relationship ends, it's good for that to have happened. Let's say we were in an abusive relationship, or we were in a relationship with someone who consistently was disrespectful toward us.
Mhm.
If we get out of that relationship and we're sad, and then we take some sort of drug to quickly get over the sadness so we can quote unquote move on with our lives, there's a risk that we're then failing to reflect on what happened
And learn
and
from it. Yeah.
learn from it. Exactly. So the interesting thing about this reconsolidation therapy is that you have to make a very specific judgment about whether the therapy or the drug is being used as a crutch to avoid learning from a thing that you need to learn from, or whether it's actually helping you productively move on and genuinely flourish with your following relationships. And that's going to be a judgment call. It depends on, with this breakup, are you, depressed for a year and a half, and you aren't able to interact with other people because you're just so much in despair. And every time you think about the breakup, do you just have a meltdown? Well, in that case, it might be helpful for you to, preserve the memory, but soften the emotional blow of the memory every time you think about that betrayal that happened. And for some people, that would help them form healthy relationships in the future. For other people, we go through a breakup and then we just plow right into another relationship, potentially with all the same warning signs and all the same problems because we didn't learn from it. So that's the sort of thing where there isn't a one size fits all answer. It's going to depend on what happened. But in some cases, it seems to me that a drug assisted therapy could be prudent in the case of certain kinds of breakup related experiences.
Yeah, it's kind of a blurry line too. I mean, it's a little fuzzy in the sense that who makes that judgment call as well. Because we've had this situation with antidepressants, for instance, that where you have family physicians and taking them. They don't really. A lot of times, I've seen people prescribed antidepressants like after just a little bit of bereavement, or where that was actually included in the DSM criteria, where you have to have, if it's been more than 6 months, yes. If it's been less than 6 months bereavement, then it's not considered. And I think they've tweaked that and they've changed that around. But overprescription of SSRIs or antidepressants, overprescription of drugs for ADHD, things like that. If you put these, I guess, neurochemical modifiers and if they're overprescribing, this could be an issue. Like if you have somebody who, in terms of not being someone who is in denial and just wants to forget things and won't be able to learn from it. It also comes down to who's prescribing. Yeah.
I think this is why, medical humanities is so important. There's a version of medicine that ends up making doctors look sort of like technicians. They identify a symptom and then they prescribe a chemical to treat the symptom. There's another model of medicine, which is doctors as philosophers, which is like reflecting on the way in which these powerful technologies can be used within the context of like systems of meaning. So, if I'm sad because my life partner died, it's not clear that treating the symptoms with a drug is even a categorically appropriate response. It's like, it might be that my sadness is so dysfunctional and so extreme that there's, good reasons for me to want to try to alleviate the sadness even by means of a drug. But in other cases, it seems like you're making a sort of an error here. This isn't like a problem of having a symptom of some sort of disorder. You're responding to life as you should, as the kind of creature that you are. So you're right that it's going to be a difficult question to figure out how you put regulations and institutional constraints in place and educational regimes in place to enable whoever it is who has the power to hand out these drugs to do so in a way that's responsive to the right kinds of things, rather than something that just becomes a rote matter of writing out scripts because people come and say, I'm sad that I went through a breakup. Well, here, take some drugs. That seems like, well, we don't want that. That's not the kind of society we want to live in.
Mm-hmm. I have, there's a comment here from Dr. Okay, this is a large comment, and I took a screenshot of the rest of it so we can see it, but it's from Dr. Lubna Mirza. It's a friend of mine. So she writes, Abu Ali al-Hussein ibn Abdullah bin Sina, okay, that's a long name, or Avicenna, yeah, in the West, was born in the village of, okay, so I'll just rush through the quote. So he said, he described the love disorder as an obsessive disorder resembling severe depression in which the patient is overloaded with imaginary figures and obsessive thoughts, Physically, this disease is characterized by poor grooming, sunken and dry eyes, repetitive blinking, and excessive laughing with intermittent crying. And then I'll read the rest of it. Cardiopulmonary changes such as rapid and paused breathing, perspiration, and an irregular pulse may occur. Inappropriate affect and sleep impairment are commonplace. The disorder may present itself as depression, mania, and conduct disorders requiring their specific treatment. So this is, it feels really sort of tongue in cheek. But you also had a quote from George Bernard Shaw in your book, who's talked about how love, how we kind of anchor our relationships on love, and love is a very, very sort of transient and intense and sort of ephemeral type of thing. So is it really something that's significant enough to merit, some of that? I mean, this is the part that I'm saying, is it really significant enough to merit all of these, treatments if needed? I mean, I know it can be very, very traumatic. So,
I mean, some people distinguish between something like early stage romantic passion or something like that, which can be very obsessive. And, when you listen to pop songs and whatever, it's often it's trying to capture this feeling. But then
limerence, I think.
Yeah.
Yeah.
And some people would say, there's more to love than a phase of love. Love is the sort of thing that may go from this excited, you can't sleep and you have obsessive thoughts and all these other bodily responses and so forth. The person comes into the room and you suddenly can't breathe and so forth. These physiological dimensions of love. It's like, if that were all love was, then, we'd have to think differently about it. But often those kinds of things, get interwoven into your narrative understanding of the person and the relationship and all that other stuff. And so love is sort of constituted not just by the physiological, but also by the narrative and by the, systems of meaning that you and your partner create, with one another.
Yeah. So we've talked a lot about romantic love, and I think your book focuses a lot on romantic love too. But there is, we know that the way that the kind of relationships we have with our parents, with our families, growing up, a lot of times they're very fraught and they're very fragile and they're very conflict ridden. In fact, sometimes I think even the relationships that people seek out, they think they're looking for happiness, but they're not really. They're looking for familiarity. I mean, they have this Pavlovian association of love as, arguing with their mother or helping their brother or sister out of a very serious conflict, or some sort of issues like that. And there is a lot of trauma that parents inflict on kids. All of us have gone through something or another similar. So are these some of these chemical modifications, do they apply to those relationships as well, in terms of painful childhood memories of maybe abuse or neglect, that I guess work on the individual more so than a relationship?
So, yeah, I mean, we made this argument that we should extend current methodologies to include relationships, but a lot of the classic work in psychedelic assisted psychotherapy is just about working with individuals on whatever they're dealing with. So a lot of people who had psychedelic assisted psychotherapy back in the 80s, but also some people who are part of these new regimes, will talk about feeling greater forgiveness for their mother, for example. So there's no doubt that although we focus on this particular thing because we think it raises some novel issues, we're embedded in a whole bunch of different relationships. And so if we can figure out how to, enhance the effects of therapy with the assistance of a drug, then all the usual stuff that applies to effective therapy applies in that case, which is, effective therapy can help you with your childhood relationships. Effective therapy can help you relate better with your boss and your children and your, friends and so forth.
Yeah, there's you also brought up, I mean, I guess, this is I guess a different topic, but in the book you also talked about how the dangers of some of these therapies, like how they were used, for example, gay conversion therapy, where it's been done, or I guess there are positive things you can do with it too. So so in cases of chemical modifications, we have sort of chemical castration for example, pedophilia, right? People, pedophiles, you can give them chemical anti-androgens to help them with chemical castration and so on. Are there other examples where these drugs can be used in situations like that? So for instance, and now I guess we're moving away from the romantic love thing, but people who have certain compulsions or certain orientations like pedophilia, or, we talked about psychopathy earlier, some of these other issues.
Mhm.
Has there been any research on that? Is that something that you came across?
Yeah, so one point to make at the outset is that a major reason why we wrote this book is to stimulate an ethical conversation. It's not just cheerleading for love drugs. The original title of the book was Brave New Love. And then for various reasons, we ended up calling it Love Drugs. But the reason why we made this allusion to Huxley is that drugs can be powerful tools for good, and they can also be really misused and really harmful and used to oppress, sexual minorities or what have you. And so precisely what we want to try to do is just get that conversation going, so that as these drugs enter in, for example, psychedelic drugs enter back into the culture through mainstream medicine, we're prepared for the ways that could go wrong. So yeah, there's different examples of people using medications for what would be considered on a progressive liberal ethics very nefarious purposes. So I talk about in the book the case of Orthodox, or I think maybe ultra-Orthodox Jews in Israel, who have kind of formed an alliance between the psychiatrists and the religious leaders to provide SSRIs indirectly as a treatment for same-sex attraction, or even
sexual impulses in general, right?
Yeah, exactly.
Mm-hmm.
And so now, I don't mean to pick on Judaism here. I'm sure this similar sort of thing happens in Christianity or in other fundamentalist sects of any kind of religion. I happen to know about this case because I read a piece in Haaretz newspaper, and then I followed up on it, and there's been some further analysis here. But what's happened in this case is that, a yeshiva student will come in and say, I have these bad feelings, I'm attracted to someone of the same sex, let's say. Now, immediately, it's very interesting here, because according to the progressive liberal worldview, that person is making a moral mistake. When they say, I have bad feelings, they're just incorrect. There's nothing wrong with your feelings. You need to get out of that crazy community that you're in. And, I am very sympathetic with this worldview, but I also try to understand the perspective of the people involved. And if you have an idea that God wants you to have a certain kind of relationship, and if you have feelings that incline you toward a different kind of relationship, it impairs your standing with God or something like that. Now, listen, I'm not a theologian. I don't believe these thoughts, but you can sort of see how this could cause great anguish for a person who feels that it isn't just as simple as, well, sure, I'll just cast aside my religion and go live a carefree life as a gay person. For some people in these cloistered communities where there's not a lot of interplay with outside forces, and where there's a lot of commitment to a particular kind of a worldview, the rabbis and the counselors will say, this student is depressed. They're depressed because they have feelings that, from their perspective, are bad to have, that cause tensions within their relationships within the community, that make them feel distant from God on their view. And so, a treatment for depression is SSRIs. So it's appropriate for us to prescribe this medication to the students because, as a matter of fact, they are depressed. But of course, in this case, they know that one of the side effects of SSRIs is that it will often lower a person's libido. Where because of the context in which these drugs are being prescribed, what's happening here is that this quote unquote side effect is now becoming one of the intended effects. So that not only do they feel there's a legitimate treat the depression thing, the thing is, we sort of hope this will lower your libido. Now, it's not going to reorient you to some other sexual orientation, but SSRIs can very effectively block your sex drive toward anyone, including the wrong type of people vis-a-vis the lights of the community. So this just creates a really difficult issue here, which is that there are lots of good reasons from a progressive bioethical standpoint to try to contest fundamentalist religious norms according to which same-sex attraction is something that God doesn't like. But that's a broader project that societies have to grapple with, that isn't unique to the issue of which drugs happen to be available to which communities when. That's something that we have to figure out from a broader perspective what to do about things like religious fundamentalism.
Yeah, that's that's such a broad thing. I wanted to actually get into one other aspect of your book about we'll get to that. I think it was the guy's name was I wrote it down here, Zach Lynch, right, who founded the Neurotechnology Industry Organization, which I love that name. But before that, I have a question here from Zuma Newport saying, if someone is a sex addict, can an MDMA drug offer the feeling of connection or of self-worth, so they do not need to, I think she's saying, act on it. So there's because you're talking about suppression, right? Or maybe treating. I think you mentioned the book that they give them naltrexone, which is used in, for example, opioid addiction and alcohol addiction.
Yeah.
And so first of all, does that have any effect on sex addiction? And what about this? What about MDMA? Because a lot of times, sex addiction is talked about as in people who feel they just need validation because they are, they have very low sense of self-worth. And that's why they go out and they try to find these superficial relationships one after the other for that. So is there a role for MDMA treatment? Do you know anything about this, or do you think it could potentially help theoretically? Or
yeah, this is very interesting. I don't know of any empirical data where anybody has tested this in any particular way. Sex addiction is also one of those contested diagnoses where people have different views.
Yeah.
Some people just say sex addiction literally isn't a thing. Other people will say, if you want to use that concept to describe your feeling of uncontrollably pursuing superficial sexual relationships in a way that some higher order rational part of you wishes you weren't doing and you find it's harmful and you can't seem to stop, well, it seems reasonable to talk about that as a kind of an addiction.
It might be, I think, because I feel like addiction may be the wrong word here. That's the part that's misleading. But you can have like normal things, like things that you're, I guess, quote unquote, addicted to, like sugar and sex. Like these can be compulsive. I mean, they're sort of like a compulsive. They can be compulsive disorder. It doesn't necessarily have to be chemical. Yeah.
You're exactly right. I mean, like one medical neuroscientific view is that things can only properly be called addictions, according to this conceptual framework, if they hijack certain neurochemical processes in the brain and they want to have all these sort of requirements of what needs to happen neurochemically. But stepping back from that, let's say we didn't know anything about what's going on in the brain. If somebody says, I find myself compulsively, repeatedly, irresistibly pursuing a certain kind of thing that's temporarily or superficially pleasurable, and yet which is having devastating consequences for my broader life circumstances and that are inconsistent with my deeper values, and I can't seem to stop. It's like, I don't know, conceptually, that seems like a good thing for us to talk about as addictive, or at least it wouldn't be unreasonable to start to use that kind of language for such a thing. So yeah, regardless of what we want to call something, there's certainly some people whose relationship to sex is like this person is alluding to, where they feel like they're doing something that's pleasurable in the moment. They can't seem to stop, but reflectively they think, I don't want to live this way. And as you point out, depending on what it is that's driving the person toward this behavior, it might be a sense of low self-esteem or something like that. And then it's conceivable that MDMA in the context of psychotherapy could enhance the effects of psychotherapy as a way to address the person's low self-regard, figuring out why do they have that feeling. Was it that their parent abandoned them as a child and they've always felt that they, needed validation from somebody else and whatever, so I don't think there's a general answer to this, because whether MDMA is going to be effective, it's likely going to be effective as an adjunct to a therapeutic process, which is going to be individually tailored to figure out what's going on with you. And, the things that might incline a person toward what we're calling sex addiction here could be any number of different things. And so if you want to get to the root of the problem, it's going to be a person by person thing. But anyway, it certainly seems reasonable that MDMA assisted therapy could help some people with this, but I don't know of any specific evidence on that.
Yeah, I mean, it seems like interesting that with MDMA, it seems like it could fit into everything, provided there is a certain context, and like you said, as an adjunct to a sort of a primary therapeutic process that's already underway. So I guess we have a few minutes left, so I wanted to talk about some of this, like the technology. So you wrote in the book, so I'll just read it out. It says, Zach Lynch, who's founder of the somewhat ominously named Neurotechnology Industry Organization, predicts that sophisticated nanobiochips and advances in brain imaging will allow for the development of what he calls neuroceuticals, or highly efficient synthetic drugs that could target specific areas of well-defined brain circuits. But this sort of finely tuned technology is only just emerging on the distant horizon. We don't know. We have no idea how long it might be before. But, nanotechnology, I mean, this is something that's been used. They're not really, it's not really medication in the conventional sense as in chemicals, but, you can have little nanobots that are built from, right from the atomic level. They're thinking about using these as, as antibiotics, to go out and kill bacteria or antivirals and so on, and for other treatments as well. So it's really interesting that this is something that can be applied to just our neurochemistry as well. So what is, can you speak a little bit more, but like what else do you know about this? Like what's on the, you said something's on the horizon. What's on the horizon when it comes to these little nanobiochips?
Yeah, I'm afraid that I've basically exhausted my knowledge in that paragraph that you read. I looked into this at the time when I was researching the book, and my impression was that it was sort of speculative, but the sort of thing that would be the holy grail of psychopharmacology, which is that anytime you intervene in a complicated, multidimensional neurochemical brain system where you're trying to accomplish one thing, the current state of technology is that you tend to have the drug do all sorts of things that weren't part of what you intended. And this is what we just call side effects. And so, you might still, all things considered, want to give someone a drug, even though it does all this other unintended stuff that maybe you wish it didn't do. But the goal of so much of this research is to figure out how can we have a targeted effect where it does the thing we want it to do, but not all that other stuff. And so this is, one researcher / business person's, proposal for how this might go. And as far as I understand, there's some preliminary research supporting the possibility of this, but I don't know any more than that.
Yeah. Okay. So yeah, that's interesting. I think something who was it that talked about this a lot? Well, I mean, not in terms of this, but it was Ray Kurzweil, actually, the futurist.
Yeah.
Who is also, and I never really know what to think of him because I mean, he on one hand he's taking 200 pills a day so he can be immortal, and he wants to bring his father back to life. And on the other hand, he got a handle on the pattern recognition thing, and he was using computers to compose music artificially intelligently, back in, I think, the 70s or 60s, I mean, right from the beginning when he was a kid. So
yeah, the Kurzweil piano, right? That's
the synthesizer. Yeah. Like his whole thing was about pattern recognition, and how human beings are unique in terms of being able to recognize patterns. So anyway, that's a whole other conversation. But he talks about this a lot, about having nanobots and then hooking them up to the internet, like these little micro.
Yeah, that's right. Are you talking about The Singularity is Near? Are you referring to his work? And I read that book in high school, I think. And he was making these kinds of arguments where, I mean, the reason why he's taking 200 pills a day, by the way, is not because he thinks the pills themselves will make him immortal. That makes him sound more cranky, as more of a crank than some people think he is.
Yeah.
His point is he wants to take all these pills so he can live long enough to reach the singularity. And the singularity is just that point where technology is evolving and sort of feeding into its own evolution at such a pace that it becomes an exponential growth to where right now, technological progress, I don't know which way my finger's going. Technological progress looks linear now because we haven't reached the elbow of the curve. And his point is that once you reach the elbow of the curve, then technology progress goes like that. And then, we're going to upload ourselves into, computers and all that kind of stuff. So he thinks that's going to happen, I think, in like 20 years. So he's trying to
he said, I think 2050 or 2045 or something like that. But that's a whole other episode. So anyway, I'm gonna finish with this. Hina Siddiqui saying, quite a fascinating topic, so many layers of physiological, pathological, and ethical nuances. I hope Brian's book is available on Audible. It's a pity the interview got interrupted. Oh, did it?
Oh,
I didn't know.
I mean, I don't know. I've been here the whole time, but maybe there's some. We'll have to patch it together or something after the fact.
Yeah, sorry about that, Hina. If it did on the stream, I guess you're watching on Facebook. It may have on YouTube. I don't think it did. But either way, so there is going to be the full video recording, and it's going to be uploaded. It's going to be on YouTube, and it's going to be on Facebook as well. And the audio version is going to be on iTunes and on all of your podcast app, Google Podcasts, and everything else. So your book, Brian, is it available on Audible?
Yes, it is. I'm the narrator of the book on Audible. So I think it's Audible. I mean, there's an audiobook version of it that's definitely available, and you can order it through Amazon, and Amazon probably owns Audible, or maybe it does. But anyway, yes, there's an audio version of the book. I believe it's available through Audible. Yeah,
that's great. So you got to narrate your own book. I didn't get to. I had mine with Tantor audio, and and I thought, I was like, shouldn't I narrate mine? Can I do it? And they're like, no, we got somebody. And I was like, well, can I try? And then they asked me, like, well, send us some voice samples. And so I sent them 2 voice samples, and then they got back to my agent the next day, and I'm like, we're going to go with our guy. And then I realized why they were right, because the guy who did it, Neil Shah, was absolutely fantastic. with the book. And he was great.
Yeah.
And I realized that, okay, it is an art form in itself. It's not easy. So kudos to you for being able to do it.
I used to, in my previous life as an actor, I used to sometimes do voiceover stuff. So I think maybe they were compelled by the fact that I'd had some previous experience with it. I actually don't like my recording all that much. I feel like I was a little too conservative in my range of vocal expression because I was trying to read it in this very serious manner. And so if I could record it again, I think it would be much more lively. But you know, people who have listened to it seem to like it. So
yeah, that's great. Everybody follow Brian Earp on Twitter. It's Brian. What's your handle? Is Brian David Earp, right?
I think so.
Yeah. So yeah, we'll put it in the description. I mean, he's got a really, really fascinating Twitter feed as well, and just online. Listen to it. If you like what you heard here today, please hit the subscribe button. This is something that I'm sort of ramping up now. It's a different kind of podcast than what we're doing with Secular Jihadists, which some of you may know. So if you can hit the subscribe button, if you you can get notified when I have other videos and other conversations like this. Previously, I had a conversation with Mookie Spitz about single dad parenting, and prior to that, we talked to Kelly Carlin, who's George Carlin's daughter, and we have some really interesting episodes coming up in the future on all kinds of different topics like secular spirituality, transpersonal psychology. I think it's going to be a lot of fun. So
I can't wait to subscribe. This sounds like a really cool lineup.
Yeah, it's gonna be interesting. I'm just going in a different direction. I still don't know what the direction is, by the way. I have no idea. That's not very good for branding in terms of podcast should really have a certain theme, and I haven't really figured it out. But I don't really care at this point, so it's okay. So Brian, yeah, thank you for joining us, and this was fantastic. It's really, really interesting, and I probably have a lot more to talk to you about. And Jim is saying, great show, made me think a lot. Yeah, so it seems it's good.
Thank you. And thanks for your great questions. This is actually a lot of fun. I've done various conversations, but your questions are particularly thought-provoking, so I appreciate it.
Oh, it was a very thought-provoking book, and it's a very thought-provoking topic, so that's why I kind of sought you out for this. And I'll bring you back for more stuff. It's just fun to talking to you. All right, guys, thank you very much, everybody, and we'll see you next time.